And Himanshi, please stop recording and start recording now, from now onwards.
Yes, sir.
Yeah, start recording now.
Yes. सर हो गया है स्टार्ट लाइव भी कर दिया है जी
Good evening, everyone, and welcome to the 8th edition of the Jaipur Surgical Tutorial Masterclass. For those who are joining us for the first time, Jaipur Surgical Tutorial, JST as we call it, is an online education portal started by us at the Mahatma Gandhi Medical College and Hospital in Jaipur in India. This is done every Saturday, 9 to 10 a.m. India time. In between, I will project a slide which will give details as to how you can join Jaipur Surgical Tutorial, those who are joining for the first time. In addition to those weekly 1-hour sessions on Saturday morning, for the last 8 months, we've been conducting this monthly masterclass, which is done on Thursday and Friday, last Thursday and Friday of a month, 7 to 9 p.m. A single theme, which is covered in 2 days, 4 presentations of 30 minutes each, covering some aspects of the theme. Jaipur Surgical Tutorial has been looked after by my colleague, Dr. Anand Nagar, who is an associate professor of HPB surgery at my institution. And technical support is provided by Dr. Avinash Tak of Dwarika Hospital, Ahmedabad, one of my former fellows from SCPGI, and his team of Himanshi and Kripa. Before we start, 2 small announcements. One, due to some personal commitments, I may not be present throughout the masterclass. So I have requested Dr. Deepak Govil, who is one of the senior consultants in surgical gastroenterology at Apollo Indraprastha Hospital in New Delhi. He will be moderating the session. The second is that the first talk, which was to be by Dr. Vinay Mahala, again my colleague here at Mahatma Gandhi Hospital, he had to rush to theater to explore a patient with bleeding. So in case he is able to join by 8:30, his part will be presented at that time. Otherwise, Dr. Jayanthi Venkataraman, who's one of the senior consultants in gastroenterology at Gleneagles Hospital in Chennai, she has very kindly agreed to cover that part also on behalf of Vinay Mahala, in addition to her presentation. So with those 2 small announcements, I hand over to Dr. Deepak Govil for moderating today's session. Thank you, Deepak.
Thank you, sir. I think it's a wonderful opportunity. And today we'll be talking about ulcerative colitis. And as you all know, ulcerative colitis is mainly a medical disease. But I think when we consider moderate to severe ulcerative colitis or prolonged ulcerative colitis, then obviously it's a disease which requires multidisciplinary treatment and where gastroenterologists and surgeons come together. So I think we have a talk, we have a plan for today and tomorrow. The first talk, as Sir said, would be on medical management of ulcerative colitis by Dr. Venkataraman, Jayanthi Venkataraman. I would hand over to Dr. Jayanthi, please.
Good evening to one and all, and thank you, Dr. Kapoor, for inviting me to make this presentation today on medical management of ulcerative colitis. So in the next 12 to 15 minutes, I'll be covering this topic. And so the talk will include a brief introduction to the subject. Then I'll have 2 cases for discussion. And what are the drugs that are available based on the site of action, those conventional and those which are in the horizon, that is on advanced therapy, and which drug to use and for how long. And finally, go to a brief conclusion. So coming to a brief introduction, ulcerative colitis, as we all know, is a colonic disease. It's an idiopathic disease where the mucosa is involved along with the submucosa. It's a continuous disease starting from the rectum. There is friability of the mucosa, And most important, it is to remember that it is a lifelong disorder with a significant impact on physical and mental health. And what's also interesting and important to know that in India, the northern and eastern parts of the country have more of ulcerative colitis, whereas the southern states have more of Crohn's disease. So the primary goal of treatment, coming to the topic for presentation today, we have to discuss on what is induction and maintenance of remission in ulcerative colitis, which will be largely a clinical remission, endoscopic and histological remission, and to obtain a sustained and durable period of steroid-free remission and achieve a mucosal healing, that is resolution of inflammatory changes, getting a Mayo endoscopic subscore of 0 to 1. And finally, improve the patient quality of life, prevent physical disability, that is mainly ileostomy, a colectomy, or a progression to colorectal cancer. So the treatment selection is largely based on the Montreal classification, and this gives us an information on the extent of the disease, whether the disease is proctitis, left-sided colitis, or it's extensive colitis as designated by E1, E2, and E3. And the disease severity is essentially classified as mild, moderate, or severe based on the UCI scoring as well as the Mayo scoring. And practice guidelines as of today is largely either a step up or a top-down procedure, largely based on the severity of the disease. Now, before we go to the evolution of the various therapeutic armamentarium that is available for management of these patients, just a brief overview on what is the pathogenesis or immunopathogenesis of inflammatory bowel disease. You can see here the inner normal healthy colonic mucosa, we have a thin mucin layer. This is largely produced by the goblet cells of the colonic lining epithelium. And beneath that are the colonocytes. So the first defense mechanism of the colonic mucosa is the mucin, as well as the goblet cells, as well as the Paneth cells. In patients with inflammatory bowel disease, due to either a dysbiosis of the gut or due to inflammatory pathology, the mucin layer gets distorted and there's a leaky intercellular pathology, as a result of which there's leakage of the bacteria or the environmental factors into the lamina propria and the submucosa. What happens here is there are two important cells that participate in this inflammatory process. We have the dendritic cells and the mononuclear cells. Both of them are involved in the extensive cascade of immune-mediated responses, resulting in production of excessive cytokines as well as chemokines. So level one is disruption of surface mucosa. Then there's stimulation of the dendritic and the macrophage cells. These are two important cells that result in the cascade of inflammatory pathogenesis in IBD. There's stimulation of lymphocytes and neutrophils. This is the adaptive type of response. And you can see here the naive lymphocytes, they stimulate the helper cells 1, Th1, Th17, and Th2. These are the three important helper cells that are stimulated, resulting once again in large number of inflammatory response that is mediated by chemokines and cytokines. As a result of this, there's also involvement of the resulting in stromal degradation and destruction of the lining epithelial cells, resulting in apoptosis as well as a leaky membrane. So this is very important that we understand, because all the target cells you see here, Th1 results in interferon gamma, which stimulates the macrophage to present TNF-alpha. That's where the our infliximab and all the biologicals act. Then we have other newer drugs that are now acting at these cytokine and chemokine levels. So this basic pathogenesis of immune-mediated pathology in IBD is very important. So over a period of time, there has been an evolution in the various drugs. Before 1930, we had no specific therapy for IBD. And then came in 1930 to 1940, where the aminosalicylates came into existence. There we have the sulfasalazine, the mesalamine, which are either oral, suppository, enema, or a foam preparation. In the 1950s, we had the corticosteroids, which are either systemic, or we have the local acting, the MMX budesonide, that is the multimatrix budesonide, and beclomethasone. And in 1960, we had the immunomodulators, azathioprine, 6-MP, methotrexate, and cyclosporin. And until this time, that is 1930 to 1960, these were, and even today, they constitute a major armamentarium in management of patients with IBD, along with the newer drugs that have come into the market. So the combination of conventional with existing therapy is the state of management in the present context. So almost 40 years, from 1930 years or so, we had these three drugs, which we were using for management of patients with ulcerative colitis. In 1990 to 2010, we started getting the biologicals, which are essentially monoclonal antibodies. And what we use in our day-to-day practice is the infliximab and adalimumab. And from 2010 to 2023, we have the integrin antagonist, the interleukin antagonist, the Janus kinase inhibitors, and then the sphingosine 1-phosphate modulators. So these are the newer drugs which are now available in the market, and they're trying to make their best to use these drugs in management of our patients. So let us take the first case, a common case that one comes across in our day-to-day practice. A 36-year-old male with history of bloody diarrhea since mid-2023, passing 3 to 4 times per day with nocturnal symptoms, with abdominal cramps and tenesmus, which is very classical of an ulcerative colitis. The tenesmus and incomplete evacuation is very classical of IBD. And this patient was afebrile. There were no systemic symptoms, and except for a mild pallor. The lab investigations revealed anemia and a thrombocytosis. Stools were negative for parasites and cultures. And based on Trulovit's criteria, the patient was in the category of a mild ulcerative colitis. So colonoscopy, we always do a limited colonoscopy during the acute phase without a preparation. We saw an inflamed mucosa with loss of vascular pattern and mild granularity and friability of the mucosa. And this constituted a Mayo score of 1 and a UCI score of 1 to 3, which is actually a mild colitis. And the biopsy confirmed that this patient had ulcerative colitis based on cryptitis and crypt distortion and goblet cell depletion. So this patient, based on the Montreal classification, belonged to E2. It was left-sided colitis with mild ulcerative colitis. Patient was started on mesalamine suppository. That's the first line of management, along with 800 milligram 3 times a day, constituting 2.4 grams of mesalamine per day. And this is the preferred dose in an acute state. We don't start with an OD dose. We always start with a divided dose in an acute state because of the intestinal hurry. Over a period of 2 weeks, the frequency subsided, and the patient was continued on treatment for the next 12 weeks until remission. What is very important is that this patient should be counseled that he does need a long-term maintenance, and over a period of time, one can stop the suppository, but one has to continue with the oral medication. So what is the site of action of these ASA and glucocorticoid preparations, which are the level 1 conventional treatment options for management of ulcerative colitis? The ASA acts on the surface of the mucosa, and it is actually acts on the pro-inflammatory mediators, which are shown here, and as well as the glucocorticoids, which act at the various interleukin levels. The ones that are marked with cross are the sites where the glucocorticoids act. So this is the mechanism of action. The action for azathioprine is largely complex, and it involves multiple systems, which is yet not clear, but it is a good immunomodulator for management of patients with mild ulcerative colitis. So the choice of drugs in mild to moderate ulcerative colitis for E1, that is rectal involvement, ASA, both for left-sided, extensive, ASA, topical, or oral plus topical, depending on the extent of disease, is the choice of drug. When they do not respond, one can include the installation of local steroids. The maintenance is always with an ASA preparation. Steroid is never recommended for maintenance of remission. I think this is also very important that one should remember. In case the patient, they do not respond to the ASA preparation, we move on to systemic steroids. And even if they do not respond to them, then comes the use of biologics. So the maintenance in such situations would be immunomodulator will be the main drug which is used for maintenance, and across all, that is both proctitis, left-sided colitis, as well as pancolitis. To take a second situation, this is a 28-year-old lady who reached UK soon after marriage and had a sudden onset of bloody diarrhea within 3 months of arrival. And this was almost 15 to 20 times a day, very severe form of disease. She was very sick. She was managed initially with IV steroids, total parenteral nutrition, as well as PRCs. When there was no response on day 5, she was also started on infliximab on day 0, 2 weeks, and 4 weeks. And there was some improvement, but not significant, to the extent that she became so ill that she required a subtotal colectomy with an ileostomy. However, since the rectum was still intact, she continued to have bleeding per rectum, and the suppositories as well as the local installation of ASA preparation did not help her. So we waited actually because she was recently married. So in 2022, she did undergo a successful pregnancy. And in 2023, an option was given to her whether she would go for an ileopouch anal anastomosis. All the points for and against were discussed. And she, however, preferred a permanent ileostomy because of the problems that was disclosed to her about the problem of the pouchitis. And now she's ready to travel back to Canada in the first week of March. So choice of drugs for moderate to severe ulcerative colitis, unlike patients with mild colitis, is now steroids with or without biologicals across the board, whether it is rectal, left-sided, or whether it is pancolitis. And in patients who are refractory either to the systemic steroids or to biologicals with or without immunomodulators, they are the ones where surgery is absolutely indicated in such patients. So amongst the newer drugs, I think this is very important that you understand here, the very first biologicals, the newer drugs that came into existence for the moderate to severe ulcerative colitis were the infliximab, which were the drugs of choice in management. We had the infliximab, and then came the adalimumab, and they are the ones that were the first drugs to be introduced. And this is largely due to the increased production of TNF-alpha by the stimulated lymphocyte, that is T helper cells 17, 1, and 2. And these cells are actually coming from the blood vessel, and those are the ones that are getting activated during active inflammation. So these are the biologicals. They are monoclonal antibodies, and they act against the TNF-alpha. The second group are the alpha-4 beta-7 integrins. These are the drugs which are currently being used. They are anti-integrins and anti-leukocyte adhesions. That is the characteristics, and vedolizumab is the drug of choice. The third drug that came into existence are the anti-integrins. And here we have they act against the cytokines, and they are the drugs that are being marketed in the present days. And JAK kinase is a new kid on the block, where we have the tofacitinib and filgotinib and upadacitinib. All these are in the trial, but tofacitinib is making a major breakthrough in management of patients because it reduces almost all the pro-inflammatory cytokines and chemokines. And the most recent and the most latest is the one that acts on the lymph node, where you have the sphingosine-1 phosphate modulator. They retain the lymphocyte. So once they retain the lymphocyte, the entire cascade of lymphocyte-mediated cytokine and chemokine-mediated inflammatory response is likely to be abolished. So currently, the role of biologicals and newer molecules will be in induction as well as for maintenance of remission in patients with moderate to severe ulcerative colitis. And many of the times now, we are able to maintain all these patients also with some of these drugs. However, patients with the infliximab and adalimumab may require therapeutic drug monitoring, as over a period of time, there can be a loss of response, especially with infliximab. I would like to mention a few points on tofacitinib, which is now becoming an upfront drug in managing patients with acute severe ulcerative colitis. It is a non-biological small molecule agent. It is not a monoclonal antibody, and therefore it has no immunogenicity. It's rapidly absorbed, available as oral preparation, rapidly eliminated, has a very short half-life of 3 hours, and it has a dual benefit of quick effectiveness and quick elimination. So that's a major advantage of tofacitinib. The low cost, an important therapy, especially for us in these countries where it is a low and middle income countries, it is affordable as a drug of choice in management of these patients. So current indications for the JAK inhibitors are both for induction and maintenance of moderate to severe naive ulcerative colitis, especially Now, currently, actually, we are using it when there's a standard conventional or biological therapies fail. But more recently, the drug is even being used as upfront as the first drug of choice for managing these patients. It also seems to have a role in extraintestinal manifestations like arthritis, ankylosing spondylitis, ocular, and other skin manifestations. The contraindications for tofacitinib are during pregnancy, elderly, breastfeeding, and patients with venous thromboembolism. Adverse effects are infection, most important being the herpes zoster infection and tuberculosis and venous thromboembolism. So in India, there was a recent publication, which is actually online, multi-center study where they had 47 cases and they found that at 8 weeks, tofacitinib caused a clinical remission of 70% and maintained at 6 months to the tune of 60%. And the independent predictor for remission of tofacitinib was the baseline serum albumin. Low albumin resulted in a poor response. And adverse effects in this particular study was essentially tuberculosis, CMV colitis. They were all less than 2%, herpes zoster, and mania. There was one other study which looked into the post-surgical outcomes in patients who were on tofacitinib, and they did find that a small percentage did have venous thromboembolism as well as post-surgical infections. So to summarize, if you have a patient with mild ulcerative colitis, the choice of drug, as I said, would be mesalamine, 1 to 4 grams per day. If there's a response, we maintain on the same drug with the same dosage that was used for induction, or if there's no response, these patients are switched over to oral corticosteroids. If there's an extensive disease, that is E3, almost pancolitis, the choice of drug remains the same. There may be a role for budesonide, multi-matrix component in a dose of 9 milligrams per day. And patients with moderate to severe ulcerative colitis, these are the patients, steroids would have a major role. If there is no response, these are the patients who would require infliximab or adalimumab in combination with the immunomodulator, that is azathioprine. So in a nutshell, mild disease, mesalamine preparations, whereas in patient moderate to severe, they are the ones who may require steroid systemic or otherwise in combination with biologicals as well as infliximab, that is with immunomodulators. Those with severe ulcerative colitis will require hospitalization, and they will require the IV hydrocortisone that is given at 100 milligrams to 3 times a day. And one would look for a response on day 3 to 5. During this period of time, all the other supportive management would be looked after. There will also be a minimal sigmoidoscopy to exclude a CMV infection. Stool cultures would be done. And one would always avoid anticholinergic or narcotic drugs. At the end of 3 to 5 days, if there is a response, then these patients are started on azathioprine along with mesalamine. However, if there's no response, they are the ones who would either require infliximab or a cyclosporin as an alternative, and they're maintained with the cyclosporin or infliximab along with an immunomodulator. Those who are refractory to either of this treatment are the ones that would go for surgery. So ultimately, the aim of management of patients or medical management of patients with ulcerative colitis is to obtain a mucosal remission. So if the patient has active disease, surveillance should be done at 3 to 6 months interval. If it is in remission, it is at 6 to 12 months. And what we're looking for is looking for remission targets by normalization of the clinical presentation, for mucosal healing with the endoscopic scores and adjunctive biomarkers such as fecal calprotectin, so that we are able to achieve a complete mucosal healing in patients with ulcerative colitis. So last word on preventive management. All patients with ulcerative colitis should be screened for depression and anxiety as they are patients on steroids. Women with ulcerative colitis are at high risk for cervical cancer, and especially those on thiopurines, and therefore they may need the papillomavirus vaccination. Screening for skin malignancies should be screened periodically, especially those on immunomodulators. Bone mineral density should also be checked, and they should be supplemented with vitamin D and calcium. And for the vaccination, in our day-to-day practice, we are actually giving them pneumococcal vaccine and influenza vaccination and hepatitis B vaccination. Herpes zoster vaccine, I think, has just appeared in the market, and some of the patients, my colleagues, have used this as a protective means in patients with ulcerative colitis. So I would like to conclude by saying that while we have huge amounts of biologics and newer therapeutic armamentarium that is available to us for management, other advances are taking place in therapeutic modalities, and these include the stem cell transplantation, fecal microbiota transplant, and these are actually therapies that are directed against the dysbiosis. However, we do not have much information on who should be the donor, the various delivery systems that needs to be opted in these patients, what should be the duration of treatment, what will be the endpoint. All these are not yet known to us. And finally, with artificial intelligence coming all along for many of the medical disorders, I think there may be a role for this as well in management of our patients. So are we heading towards a cure for ulcerative colitis? I think not as yet, because despite the availability of so many drug options, we find that we're not able to still identify the right treatment for the right patient at the right time. And outcome of any regimen that you see, whatever be the drug, whether it's infliximab or vedolizumab or any of the newer drugs, including tofacitinib, the outcome is just about 30 to 40%, except tofacitinib is now showing a response to about 60 to 70%. Safety of long-term use of any of these drugs is not yet established, so we still do not know where we are, and whether the novel treatment can improve the lives of the patients remains unanswered. But I think despite all this that we have discussed today on medical management, I think after one important thing, I always feel that when the patient is too sick, I think to me it would be that give them an option for surgery at the right time so that they have a good quality of life. Because of the number of cytokines and chemokines acting at different levels in the pathway of immunopathogenesis of ulcerative colitis, we are still not able to find biomarkers which can target at any particular site to give a cure to our patients. I think with that, I'll conclude and probably take up some questions for discussion. Thank you.
Deepak.
Yeah. Thank you. Thank you. Thank you, Dr. Jayanthi. I think wonderful display of all the aspects of medical management. I think are there any questions from the audience? You can all write in the chat box if there are any queries you want to answer. There are a few things I would like to highlight and ask Dr. Jayanthi. One is you said step up or top down approach. And that in which cases would you go for which approach usually? Usually it's a step up approach, and top down do you use in some patients?
In ulcerative colitis, it's usually step up, sir, especially the mild and the moderate ones. In severe colitis, those are the patients where we may consider, but even now, the first level one is IV steroids. And then when steroids do not work, then we add the biologicals. In that, the choice of drug is infliximab as of now. Along with, later on, we followed with an immunomodulator. So top down is more for Crohn's disease, but ulcerative colitis still seems to be a step-up approach. But tofacitinib, the All India Institute of Medical Sciences, they are using that as upfront in patients with acute severe ulcerative colitis, and they find a dramatic responses, that papers yet to be published, and they feel that it may be one of the first drug of choice not going through the steroid pathway. So that paper is yet to be published by Vinay Mahala. So that's awaited.
Right. Right. In this acute severe ulcerative colitis, as you said, that after 3 to 5 days of steroids, you would go in for infliximab and other treatment before going in for surgery. How long would you wait with these treatments before you consider a surgical intervention?
So when I see a patient with acute severe who's severely toxic, I get the surgical team in first. In fact, few patients, we've even had a immediate ileostomy to first relieve the problems related to acute severe colitis, and then take a call as to what is to be done. Because once steroids are given, then surgeons also have a difficulty in managing these patients. Right. So in acute severe, I move in the surgeon, and then we decide as to what should be done for a patient. Basically, they'll be able to guide us whether to continue and wait, or based on that clinical, it will be more like a personalized medicine at that stage.
I think we have Sujoy also with us. Sujoy, could you like this tofacitinib? If there's anything which you can...
I don't have the formal idea about this study, because right now, as far as I know, we are still doing colectomies very commonly, almost two or three times a week for all the so-called failures. But yes, there have been changes in the constitution of the patients over the time. In the past, about a decade back, it was only steroid failure. Now, of course, you have multiple attempts at, treating them, and sometimes it gets delayed because of that, and then we land up with problems also. So that has happened.
Any other queries or questions, sir?
So Dr. Jayanthi, two things from the point of view of students. One is that they are often asked the same question which Deepak asked, that suppose there is a patient with acute severe ulcerative colitis and we started the patient on IV steroids. Now, is it the number of days that you wait, or is it the response? So suppose the patient is responding, can we wait for more than 3, 5, 7 days? And if the patient is not responding, should we go in or should we change the management earlier?
So if at this is basically the Oxford criteria, Travis criteria. So by 3 to 5 days, we find that there is a significant response, systemic symptoms come down, frequency of the motion is also coming down, then yes, I think I would proceed for that. Proceed for a medical line of treatment. But at some point of time, this particular person is going to land up with a colectomy at some point. So maybe this will act as a bridge for planning for a colectomy at a later stage. And with the availability of the biologics, there are some patients who have moved around, say, for next 2 or 3 years. But if they have frequent relapses, I think that's the time when they will land up with problem. But if they're not responding on day 3 to 5 and they're still worsening, I think that will be the end point and take the patient for surgery.
Second question is the issue of tuberculosis and biologicals.
So all these patients require a screening for latent tuberculosis, sir. We have the IGRA assay, we have all patients should have a CT chest. So CT chest is a must. Of course, then we have the IGRA test and then we have the MANTU test. And we screen these patients and ensure that tuberculosis is not there. If there's any doubt, then we put them on a prophylaxis and then combine. But I've had experience of my own of patients who had very florid tuberculosis with the introduction of infliximab. They're all immunosuppressants. So screening, CT chest is more important than an X-ray chest. I think that's the answer that the examiners would want for the screening of the tuberculosis.
And the vaccination schedule which you showed is only for tofacitinib, or is it for all biologics?
No, for all. It is for all patients who are presenting with IBD, whether it's Crohn's or ulcerative colitis. What we recommend is definitely hepatitis B, because they can have a flare, pneumococcal vaccination, as well as the influenza vaccination. Herpes mainly for the tofacitinib. Tofacitinib is more for herpes.
Okay. Thank you. Deepak, please carry on.
Dr. Jayanthi, one thing I just wanted to know, what are your objective criteria of referring a patient to a surgeon and a patient with a long-standing ulcerative colitis? And have these criteria changed over the once these biologicals are here
now? I think earlier, maybe in 1990s and early 2000s and all, when I was with Dr. Surendran at Stanley Hospital, all patients with severe ulcerative colitis, he would say, why are you making the patient suffer? And he would go for a colectomy, subtotal colectomy. So those days we didn't have biologicals. But now with the biologicals in the scenario, the number of cases being referred is less. But I think most important is for the physicians to pick up those small percentage of patients who are really critically ill and, who are really and we are helpless as physicians, and that should be the case that should be referred. And ileostomy, I feel, is a simple procedure to tide over the immediate situation and then go for a second stage surgery and then a third stage. So I think it is discussion with the physician and the surgeon. Surgeon and physician I always believe in that. I've always been having a close liaison with surgeons. So I'll always have a talk with them, then talk with the patient, and then take a call.
Yeah, I think that's very important thing you pointed out, that it's a combined decision, and especially for acute severe ulcerative colitis. But I just wanted to know about the chronic ulcerative colitis. At what stage? Like if there is a young patient, 20, 30 years old, with a pan-severe colitis, when would you consider a surgical intervention in such a patient?
So in such patients, I have few patients who've been with me for 10 years who had pancolitis. They're all okay. They're all okay. They're on small dose of mesalamine and they're okay. But they started off as severe, but not very severe. but they were managed and we could manage them with mesalamine. So the chronic ones usually, except those who are followed up with surveillance for high-grade dysplasia, those are the ones who will go for definitely for colectomy. So they're on a strict surveillance. After 8 years, they're on a strict surveillance, at least with a CA, with a colonoscopy done periodically to look for any dysplasia, especially with the NBIs and all, high-grade dysplasias and all. If there's any doubt, then we push in for a colectomy. Otherwise, most of the chronic ones don't have such severe flares. It burns out. The colon burns out. So they settle down. It's actually like, it's just like a pipe stem, the colon. So they don't really have those severe flares. The initial flares are very severe. Subsequent are all mild. They just have 8 to 10, 5 to 10. We're able to salvage them with medication. And those on infliximab, we're not able to continue for more than 3 doses because of the cost. But what we say, at least give them the 3 doses and continue with azathioprine. Again, those are the patients who do not respond may land up with a colectomy. Those who are having troublesome due to economic strain, constraints, they're not able to get the medication, they're still suffering. I think they are the definite cases who require, especially in, say, in the public sector, government hospitals and all those patients are not covered by any insurance or anything. Those patients are the ones who really we pushing for a surgery rather than making them take all these drugs which are not available to them. They default on adherence and therefore they have repeated flares.
Roughly the cost of biologicals which are commonly used, are they easily affordable?
More than a lakh, sir. It comes to about, I think each dose is about 18,000, 20,000. So in a month or so, it costs about $1.5 lakh. And every 8 weeks, they have to take infliximab.
Yeah.
And we have all the problems. If they don't respond, again, we have to check the therapeutic monitoring. We have to see whether the dose is adequate. Now, this is available in very few centers. All these problems are related to that medication. So biologicals to me is always quite scary in managing such cases.
I think one of the important points you've made is that it's a combined decision usually, especially in acute severe ulcerative colitis. And even in prolonged ulcerative colitis, when you have to shift to biologicals, you have to see a lot of factors and you have to individualize the treatment and customize the treatment according to the affordability of the patient, the extent of the disease. And I think we should have a combined meeting, especially with such patients, and then decide the treatment rather than just going on to biologicals.
The problem is the severe proctitis, no? Severe proctitis not responding, whether to go for a colectomy. That's always one confusion there, left-sided. So there's nothing called a subtotal, can't do left-sided colectomy, such patients. The disease is progressive. So those are I've not had such patients. Most of them respond. Most of them do respond to the local enemas and foams and all that. But occasional cases like this lady, she continued to bleed from the rectum. She continued. Mm-hmm. So she said, I'm happy with that. You just do a mucosectomy, remove this thing, and she's got a stump closure. She's happy with the ileostomy because she's worried about the pouchitis, which was discussed with her. So the question is, I think the surgeons will answer that, the proctitis and the left-sided colitis, which is severe, not getting controlled, should we go for a total colectomy? So that is something that they always ask. For such a short disease, should I undergo surgery? And maybe these are the ones who will do well with biologicals, tofacitinib and other drugs. Because proctosigmoiditis still remains the most common site. Pancolitis, just about 1 to 2%. We don't see that many cases. At least in down south, it's very uncommon. That's what I said. North and eastern parts of the country, ulcerative colitis is dominant. Down south is mainly Crohn's. So we don't see those severe forms of, we do see, but very occasionally. Not so common.
Let's move on, Deepak.
Surgeon was telling he does 2-3 colectomies in a week. So that means it is really rampant up north. So thank you so much, sir, for this opportunity. Thank you.
Thank you, Dr. Jayanthi. I think we can move on to, is Dr. Vinay here or Dr. Jayanthi only will be talking right?
No, we will wait for Vinay Mahala in case he gets free at 8:30. So we will do that.
Okay. So we go for the next talk.
Yes.
Okay. So I think we have Dr. Sujoy Pal, who's the head of the surgical gastroenterology at the All India Institute. And he'll be talking about indications and timing of surgery, which is a very important part of the surgical treatment for ulcerative colitis. Dr. Sujoy, please.
While Sujoy is sharing the slides, I have to tell the panelists that not only the topic, but the panel has attracted more than 30 people who are currently on Zoom, and I think about 20 people are watching it live on YouTube. And in the next few days, we will see many more views on the YouTube. So thank you all very much. Sujoy, please.
Yeah.
Yes. Not getting the
Share screen. Yeah.
Yeah. Are you able to see?
No, it's a
Yeah.
wide screen Zoom. I think stop sharing and share again, maybe.
Now?
Yes,
Yeah.
yes.
Yeah.
Please start.
Yeah, so I've been asked to talk about generally surgery in ulcerative colitis with regard to indications and timing. And I mean, it has become abundantly clear from the previous talk that timing in the emergency situation or when the patient presents to us with a severe acute bout of ulcerative colitis is always a contentious issue because the patient often feels that it's possible that you can salvage the colon and maybe he or she can continue the life without a surgical option. But in our minds, sometimes these things are not easily controlled. So this is basically a brief slide which talks about the prevalence of ulcerative colitis, and it's about 43 per lakh population. And generally speaking, in India, the extraintestinal manifestations are of lower incidence. There is a lower risk of colorectal cancer, and some of the genetic associations are different as compared to the western part of the world. And 10 to 15% of patients in the of ulcerative colitis will ultimately end up requiring a colectomy within 10 years of diagnosis. Up to 10% of the patients presenting with an acute episode of ulcerative colitis will require hospital admission and will have an emergency operation out of the entire cohort of emergency admissions. And the rates of emergency surgery, as I said, have remained unchanged or somewhat decrease in very highly specialized centers, but as I said earlier, uh, our frequency of colectomies have not appreciably decreased despite the widespread use of biologicals in current practice. So, what are the actual indications then? So, in the acute, severe, or the fulminant ulcerative colitis, the most important reason and the most common or the largest cohort of patients that we get of ulcerative colitis falls in this segment, which is basically the medical rescue is failed, and here surgery has been offered as a way of terminating the acute fulminating episode. Then, of course, there is another segment of patients who have emergency complications like perforation, which can be spontaneous because of toxic megacolon, or maybe iatrogenic because of a colonoscopic induced perforation. There may be massive lower GI bleeding, which is not a very common thing, but it can occur. You have toxic megacolon, as I said, is just another way of uh, talking about the severity of acute colitis. And these are the patients where it is extremely crucial that you take a decision for surgery within 48 hours of instituting the medical therapy. There's no response clinically and radiologically. It's best to go ahead with the operation because you can land up with fecal peritonitis, perforation with significantly high mortality. Large bowel obstruction in ulcerative colitis is a rare occurrence, but when it does, you have to think about malignancy. And of course, in the chronic setting, you have situations where the patient has been having a long-standing colitis and was on surveillance colonoscopy, was detected to have high-grade dysplasia or malignancy, and he's been offered surgery as a salvage. So these are the common indications for ulcerative colitis, the most common being failure of medical therapy in the acute setting. So everybody who is dealing with surgery for inflammatory bowel disease and ulcerative colitis in particular is familiar with the true love and wits criteria, which is age old, and it's actually something which has been ingrained in the our surgical literature as well, where we have been uh, using it commonly to classify the severity based on the frequency of the stools, the blood, the temperature, the general condition, the pulse, hemoglobin, and of course, inflammatory markers. Now, it is important that when you get such a patient, you have to, of course, do a proper clinical and systemic evaluation, along with an abdominal X-ray, a gentle sigmoidoscopy with a mucosal biopsy if it's not been done previously. Take the stool samples, get it cultured for Salmonella, Yersinia, Shigella, and Clostridium difficile infection. Also, to look for CMV on the microscopic analysis. Avoid use of opioids and anticholinergic agents and antidiarrheal agents and NSAIDs in the acute setting. Use prophylactic subcutaneous low molecular weight heparin. Avoid in those patients who are profusely bleeding. And be vigilant for the development of toxic megacolon or perforation. So these are the initial steps which are common. But the main thing that you're looking at is these are the background data. In acute severe ulcerative colitis, response to steroids remain unchanged for the last 50 years. The failure rate is around 30 to 40%. And the failure following this medical rescue for failed steroid therapy is a further 20%. So the colectomy rate currently varies between around 17 to 29%. The mortality in acute severe ulcerative colitis increases with the age, comorbidity, non-response to medical therapy. And it has been shown eminently in many studies that if there is a medical rescue and that also fails, so there is no second medical rescue, should not be attempted because the mortality increases prohibitively. So the surgery has to come into the therapeutic armamentarium way, as ma'am said, that the surgeon should be involved right at the beginning when a patient of this type lands up in the emergency. So this is the famous Oxford criteria, which tells us within 3 days whether the patient is going to respond to steroids or not. So classically, by the third day, you should be able to make that judgment with 90% accuracy whether the patient is going to respond to steroids. And if there are signs which are showing that the patient is showing a positive response, then it's well worth continuing the steroid therapy. But if there are signs that there is no change, the frequency of the stools has not changed, the inflammatory markers, the anemia, the toxic symptoms have not changed at all by day 3, then it is time to consider medical rescue, or if in the absence of medical rescue, to consider for a emergency surgery. Now, it is also important to realize that if the medical rescue is being contemplated, that the team which is at hand should be well-versed and experienced in dealing with the management of such a sick patient and the use of biological agents in such a situation. And this is the study which was referring to, where rescue of a medical rescue was shown to be prohibitively toxic and way increased morbidity and mortality. So because of the fact that we have validated predictive rules, which can identify a subset of patients who will eventually fail corticosteroid therapy as early as 3 to 5 days of steroid therapy, that it is important that the decision-making is joint right from the beginning. And the issue of second-line medical therapy and colectomy should at this time be eminently discussed with the patient. And in the patient's failing one medical rescue, colectomy should be regarded as the next logical therapeutic step. So in our own experience, we have had this initial study that was published from our department, where we looked at 72 patients who had acute severe ulcerative colitis, and we had a mortality of 16.7%. And when we looked at all the patients who died, we found that most of these patients were those who had the treatment of steroid therapy was prolonged for more than 5 days. And they are the ones who ended up having a higher mortality. Of course, we had the groups with toxic megacolon and severe lower GI hemorrhage, which also had a high mortality. But refractory severe ulcerative colitis was the biggest group, and the mortality was highest for those with a prolonged treatment. So looking at using that data, when we implemented it clinically in our practice, day-to-day practice, we again reevaluated our results about 12 years down the line using the same criteria. And here we found that again, those patients who were operated less than 7 days of the initiation of the intensive medical therapy, which actually constituted 58% of this cohort that we presented in 2018, the mortality was as low as 1%. So our conclusion was that we were able to lower the mortality by implementing a strict criteria of operating patients who do not respond to steroid therapy within 7 days of institution of the intensive therapy. And here we are able to show that we could reduce the mortality of the emergency surgery drastically from 15% to about 1%. But this, of course, is a retrospective data analysis, and it's an audit of complications. It's not a prospective data, but still it's an important fact that we can look at to decide on the timing of surgery. So in the same vein, the American College of Gastroenterology and the American Society of Colorectal Surgery guidelines also suggest that you should consider a surgical plan within 3 to 5 days of intravenous steroids, specifically in those patients where failure is imminent. And when you have toxic megacolon, you should make an early decision regarding the surgery. If there is no response to medical therapy, the decision to do early surgery should be earlier in those patients with toxic megacolon. So this is actually the algorithmic approach for managing these patients. I don't want to repeat what Dr. Jayanthi has already said, but generally speaking, if the medical rescue is also part of this protocol, then by the 3rd or the 4th day, when the change from steroids to, say, for example, infliximab occurs, thereafter, or cyclosporin or tacrolimus occurs, thereafter, a waiting period of another 3 to 4 days can be given to see, look for any positive response. If there is a response, then the treatment is continued and the colectomy, the patient is spared a colectomy. But at the end of the 7 days, when the combined medical rescue is also not working, at that point of time, it is the right time to decide whether we should contemplate surgery, and probably the second medical rescue does not have a role. So you're looking at a window period of around 7 to 10 days from the index steroid therapy in such an acutely ill patient. And there has, of course, been a lot of talk about perforation, peritonitis. This is, of course, more commonly seen with Crohn's disease, but in ulcerative colitis also, as I alluded to before, it can be an end result of toxic megacolon, which has been neglected, and it could occur because of iatrogenic causes as well. And perforation peritonitis in this setting of toxic colitis carries the highest mortality in the amongst all the complications which can occur in ulcerative colitis. Abscess per se, intra-abdominal abscess per se is not a common finding of ulcerative colitis. It's more to do with Crohn's disease and perforation. By the way, Crohn's and ulcerative colitis in the toxic colitis setting have very little to differentiate clinically. They will present similarly. Obstruction is again uncommon in ulcerative colitis, but when it does occur, we have to think of malignancy. And in that situation, often the emergency situation can be tided over if there is a skillful endoscopic stenting facility available, which can tide over the emergency crisis. And the surgery can be done in a semi-elective setting with a proper bowel preparation so that the things can be sorted out without any untoward effect, and the morbidity and mortality can be minimized. Looking at the bleeding, the bowel obstruction, this is the algorithm. Ulcerative colitis, large bowel obstruction, colonoscopy with biopsy, considering stent as a bridge to surgery. Looking at bleeding again, not a very common occurrence, but when it does occur, those patients who typically require more than 5 to 6 units over a 24-hour period and the bleeding is not stopping despite the institution of therapy, are the ones who end up requiring surgery. There are two choices. You can actually either do a total abdominal proctocolectomy with a permanent ileostomy, removing the rectum totally so that bleeding is not an issue. But in many instances, we can get away with a subtotal colectomy, which is usually done. But 12% of these patients will continue to bleed from the rectal pouch. And in them, it has been seen that packing of the retained rectum, administration of mixed saline epinephrine enemas often is able to control the bleeding. And in these patients, then at a later stage, it can be converted to the staged ulcerative colitis procedure that we routinely do for most of these patients subsequently. So what procedure is done? I mean, the detail of all the surgical procedures will be talked about by Professor Das, who will be speaking after me. But the general rule is that in the emergency, subtotal colectomy with ileostomy is the preferred approach, usually with a long rectal stump, in the sense that the transection is made at the distal sigmoid rectal junction, so that we don't have to do any pelvic dissection at this time. And if the rectal stump is unhealthy, it can be brought out as a mucus fistula, either through the lower part of the wound or as a separate incision. We prefer to bring out a mucus fistula through a separate incision because otherwise wound-related morbidity is significant. And you have a terminal ileostomy, which will, of course, later on be converted after the staged procedure. Now, there are instances where we can still have to do total proctocolectomy with ileostomy. You may have a low rectal cancer, in which situation that you may have to do a total proctocolectomy and ileostomy in the emergency setting. Or you have a situation, as I said, where the bleeding is refractory and torrential bleeding is not allowing you to leave the rectal stump intact. So this is the commonest procedure done. We often leave a flatus tube in the rectal pouch so as to decompress the rectum, and we have a terminal ileostomy. The others are variants. Some people close the Hartmann's pouch just below the skin. Some deliver it as a mucus fistula, and some do a total proctocolectomy, which was the gold standard about 50 years ago, when after the steroid therapy started, the subtotal colectomy is the routine procedure. This is how the colon looks like, typically inflamed red all over with pseudopolyps, and this is a patient with pancolitis. So the rectal stump, as I said, is either left in situ or incorporated into the fascia. Stump-related problems occur in 6 to 12%, and shorter stumps are more prone to leak. So that is why we always leave a longer stump, and we also avoid any pelvic dissection at this time. So post-colectomy, there has been a lot of studies to looking at the morbidity and mortality of colectomy. And in these large systemic analysis, it has been reported that the mortality was substantial, that is 8%. And the 30-day mortality can be as high as 5%. And these are not old data. So morbidity can be as high as 50%. So mortality has, of course, decreased over in the 2000s, and the morbidity has remained still high over the last decade, largely because of repeated the wound-related morbidity and, of course, episodes of adhesive intestinal obstruction. Mortality, of course, after laparoscopic surgery has been reported to be quite low, and the complication rates have also somewhat diminished. And also the occurrence of adhesive intestinal obstruction has decreased after the use of laparoscopic surgery, but for both the subtotal colectomy, the first stage, and the later stages of reconstructive surgery. But these are the timing issues where emergency was involved. There is important timing issues and concern when you're dealing with the patient in an elective setting as well. But before that, I would like to emphasize that the second stage of the procedure that we normally do, that is creation of the pouch and doing a diverting loop ileostomy, is usually done about 6 months after the primary subtotal colectomy. And the third stage is usually done about 8 to 12 weeks after the pouch has been created, and after we are sure that the pouch has a good capacity, has not leaked, and there's no stenosis. There's a special point for women in reproductive age group. It is important to realize that when you do a pouch procedure in these patients, there's a high loss of fecundity in many of these patients, largely because of the pelvic adhesions which are created. So it is always advisable in this age group that you can defer the definitive reconstructive pouch surgery till the time that the family is completed by the patient. And this fact has to be also explained and counseled to these patients before they opt for a pouch procedure. In the setting of colorectal cancer, which was picked up in a colectomy specimen, it's important that you complete all the oncological therapy like adjuvant therapy, the need for radiotherapy before a pouch construction is done, because you cannot do radiotherapy because the pouch doesn't tolerate radiotherapy after a pouch has been created. So these things have to be kept in mind when you have a patient who has developed ulcerative malignancy in the setting of ulcerative colitis. I would end up by saying that the commonest indication for emergency surgery in ulcerative colitis, I mean, it actually remains the commonest indication in our setting as well, whereas the failed medical therapy for acute severe ulcerative colitis. Timing of surgery is the key, preferably within 7 days of initiating a medical therapy and the rescue therapy. Mortality can be reduced, as we have shown in our experience. And subtotal colectomy with endoileostomy remains the optimal surgical procedure for tackling most emergencies in ulcerative colitis. And a coordinated protocol-based approach with set timeframes for intervention, close collaboration with your gastro colleagues is very important to achieve good results. And I would always like to quote this: a coordinated protocol-based approach, set timeframes with a collaboration between a surgically aware gastroenterologist and a medically informed gastrosurgeon is vital. I've end my formal presentation. Thank you for the patient listening and thank you for the opportunity, Professor Kapoor.
Deepak.
Thank you, Sujoy. I think your last sentence was really great. Surgically aware medical gastroenterology and medically aware surgeon. I think that's the crux of the decision in acute ulcerative colitis, especially. And I think you're fortunate enough that you've been able to do surgery at 3 to 5 days with the steroid refractory acute phase patients. But otherwise, majority of the places, these patients are lingered on with the biologicals and other things before they are referred for surgical interventions. One thing I just wanted to, once these acute phases subside with medical treatment or improve with medical treatment, what percentage of these would ultimately land up with an elective surgical procedure?
Sir, I don't have any data to quote from our experience because we have very few of those patients. But I would say around 10% will land up with you in the long term.
Yeah. Because these patients, once they are better, they are more likely to have recurrent episodes and land up with a surgical
In fact,
procedure.
the data which says that
30%,
although you can defer a colectomy in the acute setting in a large majority of these patients, say around 70% of the patients, but the remnant will, in the next 5 years, at least 25 to 30%, as you said, will land up again with colectomy.
Yeah. Another thing I just wanted to ask you regarding dysplasia, I think for the benefit of students, if there is dysplasia on colonoscopy in prolonged ulcerative colitis, how do you go for a surgical intervention? In which patients would you consider a surgical intervention if there is a dysplasia?
So when we have patients with dysplasia, we are very particular about targeting the biopsies specifically in the rectum. Like we tell our endoscopists to take multiple biopsies right from the anal verge upwards, the anorectal ring upwards towards so that we can characterize the degree of dysplasia as much as we can. And if there is a dysplasia-associated lesion, that also is looked at. And in most patients in our practice, we have tried to avoid offering a pouch procedure for patients presenting with a rectal malignancy. Those who have dysplasia-related colectomies, we'll be staging the procedure in any case, and we'd like to submit it to a proper pathological examination. And if the rectum is clear of any high-grade dysplasia or malignancy, we'll probably submit it to a pouch procedure. But the other caveat is that there are patients, there are groups who also propagate surgery for patients with rectal cancer detected on the setting of ulcerative colitis to undergo pouch procedure. But we haven't done that. And in that setting, they continue to use the transanal mucosectomy as part of the procedure before doing the pouch anal continuity.
Yeah. I think that's a debatable topic. If there's a rectal
It
cancer,
remains.
should you go in
Yeah.
for a pouch? Majority
Yeah.
would avoid going in for a pouch in such a situation. And I think regarding dysplasias, I would consider if it is a high-grade dysplasia, then obviously you treat it almost more like a malignant disease and have a low threshold for a surgical procedure
Surgery.
than a
Absolutely.
low-grade or a DLM type of lesion. Another thing, just to complete the thing, any laparoscopic or other approaches for
Yeah.
ulcerative colitis in acute?
You yourself have been using robots
Yeah.
for a pouch procedure. So,
Yeah.
along with robot, both laparoscopic pouch procedure, laparoscopic subtotal colectomy, and
Right.
all these things can be done laparoscopically, and the necessary skill set is easily achievable for doing a subtotal colectomy. But for doing a pouch, there is a steep learning curve of around at
That's
least
right.
100 procedures, and that is why it's not taken up in popularity. But of course, subtotal colectomy can be done eminently. And the good thing about doing minimally invasive techniques is that the chances of having wound-related morbidity, the chances of having secondary complications like adhesive intestinal obstruction are minimized, are decreased.
That's right.
So that helps in the long term.
So in your series, how many had left-sided colitis or were they all
I was coming to that, ma'am,
pancolitis?
because when you mentioned that, this is the same dilemma that used to occur to us, that a patient only has left-sided proctocolitis and we are ending up doing a subtotal colectomy, pouch, and all those things. But of late, in fact, about 15 to 20% of the patients who present to us have severe left-sided proctocolitis. Not proctitis, just proctocolitis left-sided. And many of them are refractory to steroid therapy and other therapies. So we have actually subjected them to pouch procedures, but we have not separately analyzed both of them in our practice. But yes, we have had to do the conventional procedure is followed even if they are left-sided.
Deepak,
Yes, sir.
just a word of kind of caution to my young colleagues from my own personal experience. I was once doing a laparoscopic colectomy, total colectomy for an emergency indication in a patient with acute severe ulcerative colitis. And I tried to, as you should, stay very close to the wall of the colon, trying to do what is described as a core colectomy, that you core the colon out from the retroperitoneum and from the mesentery. But one has to be careful, because what I did in that case, I was using a harmonic, because when you are going close to the bowel wall, you are getting only the terminal branches of the arteries or the vessels, and you don't have to clip them, and you can take them with an energy source. But in that process, I probably caused a hole somewhere in the colonic wall. And then when we were extracting the specimen, we were not careful. We didn't notice that. And the entire liquid content of the colon spilled into the peritoneal cavity. And this patient, obviously, because this was an emergency surgery, she was on steroids, she was nutritionally poor, and because of this peritoneal contamination, inadvertent or iatrogenic, we lost her. So if you are doing a laparoscopic or a robotic colectomy, you don't have to do it like a malignancy that you have to go to the origin of the vessels, but stay a few millimeters away from the colonic wall, especially if you are using, which you would, energy source. So from my own personal experience, and now retrospectively, I regret that I should not have tried to stay that close to the colonic wall. So just a word of caution.
Another thing, sir, I would just add is, like if you do a diagnostic laparoscopy before starting the procedure, if you're able to hold the colon, then go ahead with the total colectomy laparoscopically. If you have difficulty in holding the colon, because many times it's very friable, straight away convert to an open procedure and do it because you should have a very low threshold for conversion in these patients with acute severe ulcerative colitis, especially.
Yeah. Actually, I don't know whether now it is mentioned or not. Earlier, it used to be mentioned in some textbooks that, and also I don't know how many of my young friends have seen a blotting paper. Earlier, when we used to use pen with an ink, after writing, especially after signing a document, we used to dry it up with a blotting paper. Now, blotting paper was a thick, porous paper, but if you dip it in water, it becomes very friable. You can't even hold it. So that is what the colon of acute severe ulcerative colitis was described. It was like a water-soaked blotting paper. You, as Dr. Deepak said, you try to hold it, it just gives way. Sujoy, you want to say something?
Sure.
Just a small update on the study that Dr. Jayanthi was referring to. I actually cross-checked with one of my colleagues. It's actually a randomized trial of steroid versus steroid and tofacitinib in the acute setting. It's not only tofacitinib. So, and this trial is still in the acquisition phase, not yet completed the number of patients targeted.
The Bombay study was a multi-center study, so they've come ahead with that data.
Maybe.
But it was a retrospective analysis, so they came out with some.
So this is
as a non-biological. They're all named patients, named acute severe ulcerative colitis. Name. The Bombay study.
I think we can move to the next talk now. Dr. Das.
Thank you. Thank you, sir.
Yeah, thank you, Sujoy. Thank you. Dr. Das, are you here?
Yeah.
Yeah.
I'm there.
Okay. Yeah, so now we have a topic, surgical procedures, definitions, the basic principles of surgical procedures. How do you choose a particular surgical procedure? Professor Dash, who is a professor at All India Institute, Department of GI Surgery, he'll be talking about the surgical procedures, their definitions. Dr. Das, please.
Can you see my screen?
Not yet, sir.
Should be.
Yes, yeah, now it's fine.
So should I make it full screen or it remains small like this?
No, full screen should be fine, sir.
Okay. Thank you, Dr. Deepak. Thank you, sir. I think I will be almost repeating in a different manner what Dr. Sujoy has already mentioned, the principles. The surgeries for ulcerative colitis has been written
you can
in the
shift to a
literature.
full screen. Sorry, you can just shift to the full screen. It's still showing small screen.
The surgeries.
Yeah, now it's fine.
I saw in the literature the surgeries for ulcerative colitis have been written as simple surgeries. So, these are quite, I think, described long back. There is very little modification in their definitions. I'm supposed to discuss about the definitions and details of the surgery, and tricks and trades will be, I think, will be discussed tomorrow, it seems. The basic idea behind treatment of ulcerative colitis is to take out the diseased colon and the rectum, and that would possibly be curative for the patient, so far as the bowel disease is concerned. So the goal of the surgery is to remove the disease without any alteration of the function or lifestyle. So the factors which are to be considered before taking a decision on the surgery are, I think, most of them have been discussed by Dr. Sujoy. The indication of surgery, emergency or complications, or the routine. What was the indication of the surgery? Age, in elderly age, obviously, we don't prefer a pouch in some of the patients. For example, I'm just citing the examples, the comorbidities, the people who are bedridden, the decision is different. If the patient is obese or morbidly obese, the decision is different. If there is presence of malignancy, the extent of resection changes. And a very important point is the anal sphincter function. If it is intact, the surgical decision is different, and if it is not intact, it changes. So it's about in 90-95% cases, it doesn't change, and the anal sphincter is intact. In 5 to 10% cases, it is not it's not continent. So we have to change the strategy. Biologicals, there are now enough studies, barring one or two, which says that in ulcerative colitis, if you are going for surgery, wait for some time before the biologicals are stopped. But most of the studies now say that they do not have any effect on the result or decision making in the surgery. And the guidelines say that if the biologicals dose has come down to 20%, then we can go ahead with surgery for ulcerative colitis. So since all these surgeries are associated with lots of changes in function, lifestyle, complications, sequelae, and the patient is mentally possibly has no idea about what is going to happen, it's very important that you discuss all these things extensively preoperatively and counsel the patient and be ready, make him ready to face the sequelae and the functional aspects, and maybe discuss some of the procedures he would like to change because of his likings or preferences. There in two settings we operate on these patients. One is a emergency setting, another is a elective setting. And in emergency setting indications, Dr. Sujoy has said, the minimum that we can do in these patients is just take out a loop ileostomy, which is very, very rare. This is done when there is very severe disease, patient is toxic and possibly cannot tolerate long anesthesia, long time for a long period of anesthesia. So a loop ileostomy, earlier on blowhole ileostomy by putting a tube into the ileum, or the cicostomy, that those are described, they're obsolete now. In my career, I have seen only 2 cases of loop ileostomy being done in these circumstances, and fortunately both of them really recovered from the toxic state. So that is to mention one. In most of the cases, of course, we do a abdominal colectomy and leave behind the rectum. But if the patient is not fit for a restorative procedure, means restoration of the continuity or restoration of the continency, then it is better to, like very elderly person or bedridden person, comorbidities like that, then it's better to go ahead with a proctocolectomy, means removal of the colon, removal of the rectum, and do a permanent Brooks ileostomy. The Brooks ileostomy by definition is a end ileostomy that has been matured. Actually, the loop ileostomy doesn't come under Brooks ileostomy, but somehow it has been interchangeably mentioned. It is a incontinent stoma, of course. And if we need a continent stoma, we can attempt for that by doing a abdominal colectomy, the proctocolectomy, and go for a continent stoma, but not in emergency setting. I'll tell in the elective setting. Majority of the cases, about 90 to 95% cases, we go for abdominal colectomy, be it minimally invasive or open. It could be a total colectomy wherein we divide the rectum just at the sacral promontory, or it could be a subtotal colectomy wherein some part of the sigmoid colon is left behind. Now, the idea is if we're doing a total colectomy, then the rectal stump has to be left inside the peritoneal cavity. And the best way to tackle this rectal stump is a staple division using a green color staple, wide mouth one, wide pins. And then the literature says that you should cover them with a second layer of sutures, maybe with Prolene. And if we are leaving behind the rectal stump, we must put a drain to drain the pent-up secretions or bleeding, small amount of bleeding that will be occurring after that. Now, the second picture shows how a stump is being left behind. and a tube has been put inside it. We can irrigate the tube with steroidal solutions in the post-operative period if it is very, very severe rectal disease. Now, what I used to do is, before dividing the rectum, I make a hole in the sigmoid colon and then irrigate the stump and do a suction and cleaning of the stump, and then distally divide it with a stapler and close it. And also under guidance, I can put a tube well into the rectum. Since usually a 34 to 40 size Malicos catheter is put, you can put a Follis catheter also. The second thing, which the Western people usually, I found they would be preferring, there are literatures for that to support also, that you keep a part of the sigmoid colon along with the rectum and then bring the sigmoid colon just beneath the wall, make a hole, make an opening in the aponeurosis, retract the muscles and keep the stump just below the skin, and then close the fascia around the stump. There are two meta analysis at least to say that the chance of pelvic peritonitis is double with rectal stump than the sigmoidostomies or sigmoid loops, but the chance of wound infection is much more with the sigmoid group than the rectal group. But if you put it just below the skin, even if it blows out or opens up, you are just to need to cut the skin a little bit and drain the sigmoid, the colon or the rectum through a tube. The least thing that is being advocated now, which I was experiencing when I was doing my residency, is to take out the sigmoid colon with like a mucous fistula, either through the lower part of the wound or through one of the sides, and then mature them. But the problem with this is high rate of wound infection, number one. Number two, this goes on discharging mucus like feces, and sometimes they have to put 2 bags, and its quality of life is not good with this. So either these two we can do, and when we will be doing a subtotal colectomy, as Dr. Kapoor said, that we have to do a core colectomy. Now, 5 centimeter of the ileum, terminal ileum, has to be with the colon, because the ileostomy which you are doing, or we are doing the pouch, the idea is to prevent, to exclude the vacuous ileitis that is occurring into the terminal ileum. This is not a proven fact, but this is what is advocated by many people. So the terminal ileum, and then we stay very close. If we stay inside the arcade, then there is a chance of injury to the colon. We just stay outside the arcade and then go on dividing the vessels. The idea is to keep the mesentery intact during the second procedure, because if you make a pouch, then the mesentery has to be supple and should be able to should be stretchable. So if there will be fibros, then it will be difficult to bring the pouch downwards. And then while we'll be removing the rectum, we have to stay in between the sphincters in an intersphincteric plane, and then with a very small skin incision, we have to complete the surgery. And then after this, we do a temporary Brooks ileostomy, complete the procedure. The elective procedures can be undertaken by open method or minimally invasive surgery that includes a single port surgery, laparoscopic surgery, or robotic surgery. The only difference between all these three now is the inherent properties of the laparoscopic surgery. That are the advantages. The leaks, the all others are subject of debate now. There are these the 5-6 types of procedure. Mainly, I'm mentioning these 5, the definition of which I'll be talking now. One is removal of the rectum, colon in toto and do a end ileostomy. One is a proctocolectomy and a continent ileostomy. The earlier one was incontinent. Then there's abdominal colectomy with ileorectal anastomosis. And there is a restorative proctocolectomy. Either you do it in two stage, 3 stages, or modified to second stage. So this is, of course, it's mostly done all throughout the world now, 90 to 95% of cases. And this is a recent technique described since 2019, rather, to do a restorative proctocolectomy and do a pouch anal anastomosis through the transanal route, transanal excision of the rectum, and do a transanal pouch anal anastomosis. Proctocolectomy and end ileostomy I have already described for the emergency procedures. Important steps are the stoma sighting is very important, and avoid autonomic nerves by staying very close to the rectum. We can go through the mesorectum. It will be a little bit bloody, but you can do a proper hemostasis. Better go through the mesorectum and do a intersphincteric dissection with a very small skin excision from outside. And meta-analysis shows that it has the least quality of life score, proctocolectomy and end ileostomy, among the 4 procedures that are described for elective setting. Then if if we can do a continent ileostomy, then we have to do a Cox pouch. I have never done, neither I have seen actually, very honestly. It is difficult to make, and if at all we can make it, then we have to use 45 centimeter of terminal ileum, make 30 centimeter of feet, a reservoir or a pouch, 10 centimeter of nipple. This will be the nipple, and 5 centimeter outlet. And this is a continent pouch. You have to empty it 2 to 4 times a day by putting a tube, and here external appliance is not needed. It is being practiced by specialized centers. The problem is difficult to make, and there are lots of complications associated, and the revision, there is a very high chance of revising the thing in the post-operative period. The quality of life has been studied. This is definitely better than the incontinent one, and in some study it has been shown to be better than the ileal pouch anastomosis procedure also. Now, the abdominal colectomy and ileorectal anastomosis can be done in a single stage in a quiescent phase of the ulcerative colitis period. This is done in patients who are unwilling for stoma or pouch, mostly elderly people, and having severe osteoarthritis, bony problems, and the persons who are having indeterminate colitis. This is a condition where we cannot differentiate between Crohn's and ulcerative colitis, and what is recommended is you just do a ileorectal anastomosis, and then see in the post-operative period, when the disease calms down, repeat biopsy may be able to show what type of colitis was that. And as Dr. Sujoy said, in younger people, younger ladies, where fecundity is a matter of concern, there we can try before their marriage, maybe, to do a abdominal colectomy and ileorectal anastomosis for preservation of the nerves. Here, the rectum is transected at the level of the sacral promontory and is never mobilized. Because if you mobilize the rectum at that point of time, next time the pelvis will be frozen, you won't be able to do a pouch. The problems are, of course, high frequency, high risk of sepsis, and there's a definite risk of malignancy in about 5 to 20% of cases. Now, that brings us to the most commonly practiced and popular choice scientifically also, the restorative proctocolectomy. The name restorative proctocolectomy, actually, I couldn't find exactly why it is called that, anyone defining that one, but what I gathered is it restores the continuity of the bowel, and it restores the sphincteric function. So it is done in three different ways. The most common and traditional being the 3-stage procedure, and it has its own indications, as Dr. Sujoy said. If we are opting that one, then then we have to do a subtotal colectomy and leave behind the rectum at the first step. And in second stage, after 3 months, remove the rectum and then make a pouch out of 30 centimeter of the terminal ileum and join the pouch to the anus near the dental line, either by hand-sewn method or by staple method. The difference between hand-sewn and staple method is that in hand-sewn, you can do a little bit of mucosectomy and directly, really under vision, join the pouch to the dentate line without any leftover mucosa intervening. But in a staple ileal pouch anal anastomosis, there is a chance that a centimeter ring of mucosa you are leaving behind there, which is prone to cause colitis or pouchitis. Again, these are not proved. These are all speculations. And then we have to do it a temporary loop ileostomy to complete the procedure, and the loop ileostomy is closed after another 3 months. In a traditional two-stage restorative proctocolectomy, we do a total proctocolectomy and a ileal pouch anastomosis and a temporary loop ileostomy in the first stage. This is where the disease is quiescent, and there is no emergency procedure done in this patient. And then after 3 months, we do a ileostomy closure. And there is this recently published articles on modified two-stage restorative proctocolectomy, wherein the first step is subtotal colectomy and temporary loop ileostomy. And then after 3 months, do a proctectomy, a removal of the rectum with ileal pouch anastomosis and no temporary loop ileostomy. There has been comparative studies between second stage versus modified second stage, and it is said that the quality of life, the leakage rate, all these are better in comparison to the traditional second stage in adult patients with ulcerative colitis. This is not same in pediatric group of patients. We can do a ileal pouch distal rectal anastomosis, that is 2 centimeter above the dentate line. Some people have done it, and I think if I have seen some of the inexperienced people at the starting point of their career, they actually tend to do it inadvertently while doing a pouch anal anastomosis, because the problem is the contour or the stapler which divides the rectum. It's very difficult to reach the lowermost level. It needs a little bit technical expertise to mobilize the rectum, particularly anteriorly from the bladder and the seminal vesicles and the prostate, to get a proper firing of the stapler as near to the dentate as possible. And recently, sir, are you saying something? Hello?
No,
No,
please.
carry on.
I was just checking the YouTube on my mobile phone. Please carry on.
So, in 2019, this procedure was actually published and now getting popularity, where this is a transanal ileal pouch anal anastomosis, wherein the rectum is dissected out the transanally under laparoscopic vision. And then through the ileostomy wound in the abdomen, the bowel is delivered and the pouch is made. And guidance through it, drain tube, this can be guided down to the anus and do a stapled ileal pouch anal anastomosis. There are certain special circumstances in which we need to modify the procedures or remember what not to do. One of them is indeterminate colitis, where I said the difference between Crohn's and ulcerative colitis couldn't be made. So do a initial Hartmann's procedure. Now, defining a Hartmann's procedure. Hartmann's procedure is actually a sigmoidectomy and closure of the rectum and leaving behind it. But people used to interchangeably use this one for any form of colon dissection and leaving the rectum behind, or even a part of the sigmoid colon behind. So it's a initial Hartmann's procedure, and later wait for the disease process to cool down and do biopsy and see for differentiation. In case of primary sclerosing cholangitis, it is advised to avoid ileostomy because later on they would have cirrhosis, portal hypertension, and there will be development of varices and bleeding around the ileostomy. If there is colon or rectal carcinoma, so what is recommended is, if it is limited to the upper third, then and in early stage, you can go for a ileal pouch channel anastomosis. And if it is middle or lower, the guideline says that you should not do ileal pouch anastomosis. But 2022, 2023 articles have shown that you can, even in middle third also, if you're getting a good margin, then you can still go for a ileal pouch anastomosis. Now, lastly, a word about appendectomy only. This is a very interesting subject. There's a patient trial to say that in ulcerative colitis patients who are not in emergency and they are on drugs, if you do a appendectomy in these patients, the response to the drug becomes better, and the recovery of these patients becomes better. Now, this is again under study because the follow-up of these patients are yet to come. So whether or not appendectomy only will be able to help or not, if I go by the trial, it looks quite promising. So summarizing, there are 4 types of procedure commonly performed for ulcerative colitis. All of them involve resection of the colon with or without rectum. The ileal pouch anal anastomosis and ileorectal anastomosis, they restore the continuity. That means 2 procedures restore continuity. And in one procedure, we do ileostomy after total proctocolectomy. If we need to do a continent ileostomy, go for Cox pouch. And compared to open, minimally invasive surgery offers short-term benefits. The newer technique, that is transanal ileal pouch anal anastomosis, has comparable outcomes shown in small studies. And in emergency, the preferred surgery is total abdominal colectomy. Ileostomy is the procedure of choice. In elective setting, most patients should undergo restorative proctocolectomy, ileal pouch anal anastomosis. Other procedures are rarely used in specific circumstances. Thank you.
Yeah, Deepak.
Thank you. Thank you, Dr. Das. I think you wonderfully explained all the details and all the specific instances where there are variations in the surgical technique. I think we've covered majority. I just would like to stress a few points which I think you've already made. One is preoperative counseling. I think for a ulcerative colitis patient going in for surgery, preoperative counseling is one of the very important aspect of the treatment, because you have to sit with the family, explain to them all the pros and cons of the surgical treatment. So that's a very important point which should be done with great detail. And other things, I think a sphincter tone is very important. You should always examine the patient preoperatively, properly. In fact, anal manometry today is said as regularly you should be doing anal manometry if there is a facility available before you go in for these procedures, because the outcomes and the post-operative morbidity, number of stools and other things all depend a lot on the anal sphincter's function, basically. I think majority of the things have been covered. Any other points by any other faculty or any other students, please?
Yeah, so I have 2 or 3 questions on behalf of the students. Both Das and Sujoy can take them. One is, when you are dissecting the rectum, which plane do you go in? The mesorectal plane, as we do in rectal cancer, or you stay on the rectal wall and leave the mesorectal fat behind? What are the pros and cons?
So, in case of ulcerative colitis, not malignancy, when we are going through the guideline says that you should go trans-mesorectal, through the mesorectum. So what we do is, in first stage, when you do a subtotal colectomy and leaving behind the stump inside, we attach a big size Prolene suture for identification, because identification in these people are difficult. So once you catch hold of the Prolene and lift it up, then you can see a fold close to the rectum on either side. You open the fold of the peritoneum on either side first, not behind. Then once you open the fold, you can see thick mesorectum behind the rectum. So initially, I would suggest, if you are not you are experienced, then better to start dissecting as close to the rectum, because at the promontory itself, the superior inferior hypogastric plexuses, they dip inside and remain close to the rectum. That is where you have to go inside the mesorectum and leave behind the fat, the surrounding fat. But it is quite bloody procedure.
Yeah, so that was the reason I asked that if you are going through the mesorectum or between the mesorectum and the rectal wall, then you are going to have a little more bleeding, isn't it?
Yes.
On the other hand, people who go outside the mesorectum, in the mesorectal plane, as we do in the rectal cancer, they say that it will be bloodless, number one. And number two, you will have more space for the pouch to come down, especially in a narrow male pelvis.
Yeah. Can I come in, sir?
Yes, Sujoy, please.
Most of the surgeons who are adept at doing the minimally invasive restorative proctectomy, they would actually like to adhere to the principles of oncological surgery while they are dissecting the rectum, because they feel it makes it much easier laparoscopically. Using the vision is also good, and they are able to see the nerves anyway, so they are going to prevent injuring it. At the same time, use the plane which is relatively bloodless. So that is one difference between how we do it in the open and how the minimally invasive technique has evolved.
I agree on that. Actually, the planes are much more easier when you do it with a minimal access technique. And we prefer to go in the same planes which we are used to dissecting while we are doing malignancy surgery. And it is much more neater procedure, because going through the mesorectum is a very bloody procedure, which in open probably you can manage, but laparoscopically it may become much more messy.
The second,
Sir,
please.
that is perfectly fine. But in malignancy, we are not so much worried about the nerve injuries. And when you go from the sides, ultimately at one point you have to enter the mesorectum to reach the rectal wall before stapling. So if you are technically adept, then you can go through what the literature says. I also go through mesorectum, but yes, I have found in some obese patients, there is a really thick mesorectum, and once you go around, you find very little space, but it has never hindered the pouch to go through and reach the pelvis. But I think there would be, that is my feeling, I'm not analyzed, but I think the chance of pelvic collection would be more in these patients.
Right.
So adequate drainage, as has been recommended, that adequate drainage of the pouch is very essential. Of the pelvis is very essential.
There's one more small point I wanted to bring, which is, I mean, it is quite rightly pointed out by you, Dr. Kapoor, Dr. Das, that you are coring out the colon, as so to speak, in the emergency situation, and trying to core out, leaving, don't target the central vessels. There is another technique which is evolved basically in patients in whom you you are able to predict that the ultimate pouch construction and the pouch reach to the superior part of the dentate line will be difficult at a later date when the patient comes for the restorative surgery. These are tall patients, tall, obese male patients, where you anticipate difficulty. So here, it is recommended that if you can preserve the marginal artery of Drummond on the right side, which communicates between the middle colic and the ileocolic trunk. If you can preserve the marginal artery of Drummond, that means you're just targeting the vasa recta along the marginal artery of Drummond, preserving this thing. This can be a collateral circulation, which can be used to, increase the reach of pouch when you are in difficulty. By, you can take away the segment of ileocolic artery and the entire supply will come from the marginal artery of Drummond. That gives you at least 5 centimeters of extra reach to the lower part of the floor. So this is just one technique which can be used in the elective setting.
Another thing I just wanted, like the modified two-stage, as Dr. Ashwin said, I think I would still be wary of doing a pouch anal anastomosis without an ileostomy. Although, if the patient is off the steroids and these immunosuppressants, probably it may be possible, but literature is showing that probably that is acceptable and the results are better. But I would still be very uncomfortable doing it without an
I would
ileostomy.
agree to that it should be in selective patients. But if you
That's right.
see Cleveland Clinic experience, they
Sure.
always do modified second.
Right. Yeah.
So I think the biology is important.
Sure. I think we have Dr. Vinay.
Deepak, we have about 12 minutes because in the masterclass we finished at 9. I may have to leave. I have some guests at home. I had sent them off somewhere, but now I have to go and pick them up. So, Dr. Jayanthi, may I request you to please very briefly cover what Vinay has sent you in about, say, 10 minutes.
Can you ask the host to allow me to share the slides? I'll finish up in 10 minutes.
Yes. Himanshi, please allow Dr. Jayanthi again to be the co-host. And then Deepak, you can make some concluding remarks and then close. So I will take leave, please.
Thank you.
Thank you. Thank you so much.
Thank you, sir. And I'll just cover this topic, which was not covered in the initial phase. And I think this is an important topic because the entire management of ulcerative colitis is ultimately dependent on the assessment of the extent and severity of the disease. This talk was to be delivered by Dr. Vinay. He's busy with a surgical procedure, and hence I'm presenting on his behalf on his slides. So the points for discussion will be just again a brief introduction. There'll be a lot of overlap with already most of the things that have been covered. The clinical scoring system stresses the disease extent and severity, the laboratory tests, and the endoscopic evaluation. So this we have already covered. Just to recapitulate the fact that ulcerative colitis is a disease which is starts from the rectum, restricted to the mucosa and submucosa, and it's a lifelong disorder. So it is typically characterized by relapses and remissions, and the hallmark is classical blood diarrhea with rectal urgency and tenesmus, and extraintestinal manifestations occurs in about 20% of patients. So the key diagnostic features of ulcerative colitis we've been discussing throughout this evening they are the clinical features. Classical is the bleeding per rectum, the endoscopic features, which I'll be mentioning and discussing about that, the laboratory investigations, where CRP may have a role along with fecal calprotectin, and classical histological findings of goblet cell depletion, ulceration, cryptitis, and cryptapsis with crypt distortion, branching, and atrophy. Why do we need to define the severity index? It is important because this serves as a guide to select the case for appropriate treatment, whether it is surgical or medical. I think that's very important, and hence we need to know the extent and severity of the disease. It also helps to prognosticate the patient's condition. So let us go through some of the clinical scoring systems. All of them are actually done on the calculator. So we have the Mayo score, We have the score ranges from 0 to 12, the highest score that indicates a more severe disease, scores that are compared with previous scores for response to treatment. And then we have the Mayo Index, where we have the physician's global assessment and other criteria that includes the patient's daily abdominal discomfort, general sense of well-being, performance status, and physical findings. The second classification, the Montreal classification, which has a severity index of 0, S1, S2, S3, and S4. Basically, it contributes to the number of stools per day. So that assesses the severity of the disease. True love and risk criteria was also discussed by Dr. Sujoy. And this is, I think, a simple index that can be done in day-to-day practice, which helps us to classify the patients as mild, moderate, and severe. And coming to the next, so the laboratory tests, the common biomarkers, day-to-day practice, we use the ESR and C-reactive protein, very specific, but it does give us some information on the activity of the disease, whether the disease is in remission. Can you all please mute your... Okay, and includes the fecal calprotectin and fecal lactoferrin. And the cutoff for the CRP is less than 5 to 6 milligram per liter. Fecal calprotectin and fecal lactoferrin, they are quite specific for interstitial inflammation. And we have the values mentioned here, between 50 and 250 for fecal calprotectin and fecal lactoferrin are 7.25 to 10 milligram per gram, which is almost similar to fecal calprotectin. This is what we do in our day-to-day practice. It is an expensive test. So we do that in patients who have a flare, and we're not quite convinced whether it is a flare due to IBD or it is otherwise an unknown cause for the flare. Coming to the last bit, the endoscopic scoring systems, we've already discussed this. The E1 is rectum involvement, E2 is left-sided, E3 is extensive. And for the severity, we have patients who have no symptoms, those with mild ulcerative colitis, who pass motion 4 to 6 times per day or less than that. Moderate are those who pass more than 4 times with minimal systemic toxicity. And severe ones are the ones who have florid systemic symptoms such as fever, low hemoglobin, and raised ESR. This we've already discussed, so I'll not be mentioning, except to mention that majority of our patients are proctitis, and they have the classical tenesmus and urgency. The left-sided colitis presents with a minimal abdominal cramp and all of the findings of proctitis. And the pancolitis has systemic symptoms. Most of them have systemic symptoms, and they are the ones who have severe forms of disease. So we have 2 scoring systems for endoscopic assessment. We have the UCI scoring and the Mayo score, and it is shown here. And if the score of UCIs is 7 to 8, it is severe. For the Mayo, it is 3. So these are the simple endoscopic scoring systems. While reporting an endoscopic colonoscopic report, we use this calculator and mention to the patient whether in the reporting system, whether the patient has mild disease, a moderate disease, or a severe disease. I think so. With that, I'll just mention, just to conclude, that in day-to-day practice, simple scoring systems like clinical scoring, laboratory scoring system, and endoscopic scoring systems are sufficient for us to guide us towards management, whether the patient would require a medical treatment or a surgical treatment, or we have a treatment schedule where the 2 of us combine together to help the patient to help in recovery as well as in maintaining remission of the disease. Thank you for your kind attention. Thank you, sir.
Thank you. Thank you, Dr. Jayanthi. I think that was a very brief and crisp presentation. And we've covered most of these are regularly used scoring systems, which are being used for clinical scoring and for endoscopic scoring. I think overall, we've covered the initial aspect of ulcerative colitis, the medical management, the assessment of severity and extent, the indications and the surgical treatment. I think the basic things which are important is, again, it's a disease which requires a multidisciplinary treatment with both the medical gastroenterologist and the surgical gastroenterologist, especially in the acute phase, working together and taking decisions together to have a better outcome for the patients. And other important thing, which again I would like to highlight, is a preoperative counseling is very important. And for these patients, planning a procedure should be customized to every patient. And we should are on the side of doing a 3-stage procedure if the patient is sick and on immunosuppressors rather than a 2-stage procedure. And the details of the procedure have been well covered by Dr. Das. I think with that, we can conclude the session today. Thank you, everybody. Thank you, Dr. Jayanthi, Dr. Sujoy, Dr. Das. And thank you all students for participating. Thank you.
Thank you very much, sir. Thank you and good night. Thank you.
Good night.
Thank you.
Good night.
Yeah.